Great. All right. Well, welcome back to Health Healthcare. So our last bit of work today is we're going to walk through a draft of a, or not a draft. We're going to walk through a bill that was introduced this week by myself and 79 other colleagues. And so H721 has a lot in it that Jen will walk through today. But the general premise of the bill, and I'll just kind of be like the sponsor introducing the bill, that we hear a lot about affordability and access issues in Vermont with healthcare, and we are working really hard to bring down the cost of healthcare through our value-based payment programs, our all-payer model, the things we're doing for hospital sustainability. But we really need to start looking at what Vermonters pay for healthcare and how we can make it more affordable and accessible. We found through the pandemic that Medicaid worked for a lot of people. We know Medicaid is a well-run program in Vermont. And so I drafted this bill to expand Medicaid in several different areas, as well as increase provider reimbursement rates. It's the only way we can do the expansion. We have to pay providers what they should be paid for Medicaid. And then there's some administrative, I'll call it administrative bucket things in here that I think we as a committee should look at. I don't know if there's any questions for me as the sponsor of the bill, or we'll just have Jen walk through it.
How do we compare with other states in terms of Medicaid?
Generally, we have a very robust Medicaid program. It's run by the state. Other states run it through actual insurance companies. And so we're, I think, pretty unique in that way.
We run our Medicaid
correct.
System versus
an insurance company running it. So we basically, DEVA is an insurance company, but it's state run versus like ABC insurance company might run the Medicaid program in Idaho.
And does that private company bill the state of Idaho?
Yes.
So they bill the state for what?
Yes, so Medicaid, no matter how it's run, it is a state-federal partnership.
All right.
So dollars come from the general fund of every state.
Yeah.
Great. Thanks, Jen.
Sure. Jennifer Garby, Legislative Counsel. So I'm going to put the language up on the screen here for H721, which, as the chair said, she is the lead sponsor, and I believe there are 8 other members of this committee also co-sponsors. So hopefully some of you have seen the bill before. All right, so it's the bill is entitled, I'm going through all the sponsors and then the statement of purpose, but it is an act relating to expanding access to Medicaid and Dr. Dinosaur. It starts with a short title saying the act shall be known and may be cited as the Medicaid Expansion Act of 2024. Then it goes into a bunch of findings. I don't know how much you want, Madam Chair, to go into the findings or not into the findings. I can.
Can you breeze through them?
Sure. So the first finding is about, several findings are about Medicaid. The first one describes Medicaid as a comprehensive public health insurance program funded jointly by state and federal governments. Talks about the coverage under Vermont's current program. So adults with incomes up to 133% of the federal poverty level, children up to 19 years of age from families with incomes up to 312% of the federal poverty level, and pregnant individuals with incomes up to 208% FPL. Second finding is that states can customize their Medicaid programs if they get permission from the federal government to do so. Vermont is the only state in the nation that operates our entire Medicaid program under a comprehensive statewide demonstration called the Global Commitment to Health. Sometimes we call it just Global Commitment, that offers the same services to residents in all parts of the state. Vermont's unique Medicaid program provides comprehensive coverage for a full array of healthcare services, including primary and specialty care, reproductive and gender-affirming care, hospital and surgical care, prescription drugs, long-term care, mental health, dental and vision care, disability services, substance use disorder treatment, and some social services and supportive housing services. For the most part, there are no monthly premiums for most individuals covered under Vermont's Medicaid program, and copays are minimal or non-existent for most Medicaid coverage. And it gives us an example. The highest copay for prescription drugs for a Medicaid beneficiary is $3. Almost 1/3 of all Vermonters, including a majority of all children in the state, have coverage provided through Medicaid, Vermont Medicaid, which makes it the largest health insurance program in the state. Then we get into some findings around uninsured. So in 2021, the 6% uninsured rate for Vermonters who had annual income between 251 and 350% the federal poverty level was double the 3% overall in uninsured rate. And for people 45 to 64 years of age, the estimated number of uninsured Vermonters increased to more than 50% over the previous, over the previous 3 years, from 4,900 uninsured in 2018 to 7,400 in 2021. Seventh finding is that cost is the primary barrier to health insurance for most uninsured Vermonters. More than half, 51% of uninsured individuals identify cost as the only reason they do not have insurance. During the COVID-19 public health emergency, the uninsured rate for Vermonters with incomes just above Medicaid levels, between 139 and 200% of the federal poverty level, fell from 6% in 2018 to 2% in 2021. And this drop was due in large part to the federal Medicaid continuous coverage requirement, which we were talking about as recently as yesterday, which allowed individuals to remain on Medicaid throughout the pandemic, even if their income rose above the Medicaid eligibility threshold. A majority of Vermonters, 56%, with incomes between 139 and 200% FPL, were on Medicaid in 2021. The end of the public health emergency and the beginning of the federally required Medicaid unwinding means that many of these Vermonters are losing their comprehensive, low or no cost Medicaid health coverage. 10th finding says that almost 9 in 10, 88% of insured Vermonters visited a doctor in 2021, compared with just 48% of uninsured Vermonters. Insured Vermonters are also significantly more likely to seek mental health care than uninsured Vermonters, 34 versus 21%. And marginalized populations are more likely than others to forego health care due to cost. Vermonters who are members of gender identity minority groups are the most likely not to receive care from a doctor because they can't afford to. That's 12%. In addition, 8% of each of the following populations also indicated they are unlikely to receive care because of the cost: Vermonters under 65 years of age who have a disability, Vermonters who are Black or African American, and Vermonters who are LGBTQ. And we get into some findings about the underinsured. Many Vermonters under 65 years of age who have insurance are considered underinsured, which means that their current or potential future medical expenses are more than what their incomes can bear. The percentage of underinsured Vermonters is increasing from 30% in 2014 to 37% in 2018 and to 40% in 2021. Vermonters 18 to 24 years of age are the most likely to be underinsured among those under 65 years of age, with 37% or 38,700 young adults falling into this category. The highest rates of underinsurance are among individuals with the lowest incomes, who are just over the eligibility threshold for Medicaid. Among Vermonters under 65 years of age, 43% of those earning between 139 and 150% FPL, and 49% of those earning 151 to 200% FPL are underinsured. Underinsured Vermonters 18 to 64 years of age spend on average approximately 2.5 times more on out-of-pocket costs than fully insured individuals, with an average of $4,655 for underinsured adults compared with less than $1,900 for fully insured individuals. Individuals with lower incomes or with a disability who turn 65 years of age and must transition from Medicaid to Medicare often face what is known as the Medicare cliff, or the senior and disabled penalty, when suddenly faced with paying high Medicare costs. Individuals with incomes between $14,580 and $21,876 per year, and couples with incomes between $19,728 and $29,580 per year can go from paying no monthly premiums for Medicaid or Vermont Health Connect plan to owing hundreds of dollars per month in Medicare premiums, deductibles, and cost sharing requirements. Finally, we talk about coverage for young adults. The Patient Protection and Affordable Care Act, the ACA, allows young adults to remain on their parents' private health insurance plans until they reach 26 years of age. The same option does not exist under Dr. Dinosaur, Vermont's public children's health insurance program, established in accordance with Titles 19 and 21 of the Social Security Act. However, so young adults who come from families without private health insurance are often uninsured or underinsured. In order to promote the health of young adults and to increase access to healthcare services, the American Academy of Pediatrics recommends that coverage under Medicare and SCHIP, which in Vermont means Dr. Dinosaur, be made available to all individuals from 0 to 26 years of age. Let me get into some of the statutory provisions. Section 3 amends the Medicaid administration of the Medicaid program in 33 VSA section 1901 to increase the income eligibility for Medicaid over time. So this would say income eligibility for Medicaid for an adult who is 26 years of age or older but under 65 years of age and is not pregnant shall be as follows. Until January 1st, 2026, 133% of the federal poverty level for the applicable family size. That is the current eligibility rate. And so that would stay in effect until January 1st, 2026. From January 1st, 2026 until January 1st, 2028, 185% of the federal poverty level for the applicable family size. From January 1st, 2028 until January 1st, 2030, 250% of the federal poverty level for the applicable family size, and beginning on January 1st, 2030, it would go to and stay at 312% of the federal poverty level for the applicable family size. On page 10, we also have eligibility expansion for Dr. Dinosaur. So this would require the
Okay, keep going.
Would require the Secretary of Human Services to make coverage under the Dr. Dinosaur program available to the following individuals whose modified adjusted gross income is at or below 312% of the federal poverty level for the applicable family size. That's all Vermont residents up to 26 years of age and pregnant individuals of any age. So just as a reminder, on current Dr. Dinosaur levels, the income threshold is adjusted gross income at or below 312% of the federal poverty level up to age 19. So this would increase that to up to age 26. And for pregnant individuals, it is currently 208% of the federal poverty level, or up to 208% of the poverty level. So this would increase that to at or below 312% for that population as well. And then in subsection C, there's current ability for the Secretary of Human Services to charge a monthly premium as set by the General Assembly per family for pregnant women and children eligible for with incomes over 195% who are on Dr. Dinosaur. This would expand that definition to be for pregnant individuals, which is the language we're trying to use, children and young adults, because we've created that eligibility group from 19 to 26. And any co-payments, co-insurance, or other cost sharing to be charged under existing law says shall also be authorized and set by the General Assembly. This says it would be a set or established by the Agency of Human Services, but still require that authorization from the General Assembly. Next is really just on the top of page 12. No, where am I? Where did I go? Okay, so the only changes on page 11 are, the first one is just a technical correction to update the name of the Health Reform Oversight Committee, which was at one point the Health Care Oversight Committee. And then to keep the prohibition on a prescription co-payment for people on Dr. Dinosaur. Currently, it is under age 21. This would increase that to under age 26 to go along with the expanded eligibility. Then we get to page 12, section 4 on the Global Commitment Fund. So there is already an existing law, a requirement for an annual report to the Joint Fiscal Committee on the Managed Care Organization investments or Global Commitment investments under the Global Commitment Waiver. This would require some additional information. So in addition to the annual report, it would also require the Agency of Human Services to provide specific information about the Global Commitment investments annually as part of its budget presentation. And it allows, so basically providing information on the Global Commitment investments, we'll go over the list, but there are a lot of them. So this says the agency may choose to provide the required information for only a subset of Global Commitment investments in any 1 year, provided that it must provide information for not less than 20% of all investments in any 1 year and shall rotate the investments it's reporting on so that it's reporting on all of them at least once every 5 years. And the information to be provided must include a detailed description of the investment, which Vermonters are served by the investment, the cost of the investment, the efficacy of the investment, the amount of return on the investment, if applicable, and where in state government the investment is managed, including which division or office is responsible for that management. Section 5 would enact a new section on Medicaid reimbursement rates for certain services. This would require the Department of Vermont Health Access to reimburse providers for delivering primary care, mental health, substance use disorder treatment, and long-term care services in amounts that are greater than or equal to 125% of the Medicare reimbursement rates then in effect for delivering the same services. Similarly, in Section 6 for dental services, this would require an existing law. It requires DVHA to have a reimbursement structure for dental services in Vermont Medicaid. This would specify that the reimbursement rates must be greater than or equal to 125% of the rates then in effect through the commercial dental insurer with the largest market share in Vermont for delivering the same services. Medicare does not cover dental services. This is currently, I think, a reference to Delta Dental, but it would change if there was a different commercial insurer with the largest market share. Section 7 makes some changes relating to the Clinical Utilization Review Board. Some of them are really just cleanup changes because this was language that was important at the time it was enacted, but right now we don't need requirements that things occur no later than 2010. But there is a Clinical Utilization Review Board. There will continue to be in the Department of Vermont Health Access. Its role is to examine existing medical services, emerging technologies, and relevant evidence-based clinical practice guidelines, and to make recommendations to DVHA regarding coverage, unit limitations, place of service, and appropriate medical necessity of services in the state's Medicaid program. That's existing law. Some of the changes are, there are 10 members on the board. Currently, they are all appointed by the governor upon the recommendation of the commissioner of DVHA. This would change that to instead have 4 members appointed by the governor upon the DVHA commissioner's recommendation, 3 members appointed by the Speaker of the House, and 3 members appointed by the President Pro Tem of the Senate. It would also, again, in what is now Subdivision 4, get rid of clean up some outdated language about meetings during the initial 6 months. And then under the list of the board's duties and responsibilities, would add a duty on page 16 to consult that this is the Clinical Utilization Review Board, that the Clinical Utilization Review Board consult with DVHA's Drug Utilization Review Board as appropriate to coordinate Medicaid prescription drug coverage in connection with covered services in order to optimize patient outcomes. Subsection D is just a change for non-gendered language. And then new provision in a new subsection E. that would require at least annually the DEVA commissioner to report to this committee, the Human Services Committee, and the Senate Health and Welfare Committee, the services that the Clinical Utilization Review Board has reviewed, considered, or recommended as part of its role. And then within 30 days following the receipt of an inquiry from a legislative committee or committees regarding new or expanded Medicaid coverage of any service, the commissioner would be directed to provide that inquiry to the Clinical Utilization Review Board for its consideration. And the commissioner would include the board's response to each of those inquiries in the commissioner's next annual, or at least annual report. So this is a requirement that if you as the House Healthcare Committee or another committee or committees wants to inquire about new or expanded Medicaid coverage, then the Clinical Utilization Review Board would be at least have a role in reviewing and responding to that inquiry. It also specifies on the top of page 18 that nothing in this section shall be construed to limit the authority of the General Assembly to require Medicaid coverage of any service. This is allowing you a new opportunity to consult with the Clinical Utilization Review Board, but it does not do anything to the General Assembly's authority to make changes or regulate regarding Medicaid coverage. Section 8 is really a conforming change for the Dr. Dinosaur-like coverage for individuals who are Vermont residents with an immigration status for which Medicaid coverage is not available. So you may remember, those of you who were here a few years ago, you added provisions to require Dr. Dinosaur-like coverage for children under 19 years of age whose household income does not exceed the income threshold for eligibility under the Vermont Medicaid state plan. So basically putting them on something just like Dr. Dinosaur, except we can't run it through the same program, same state federal program because of their immigration status. This would expand that coverage for that group to include the young adults up to age 26. So people from 19 to 26, which would line up with the Dr. Dinosaur coverage from earlier in the bill. Section 9 would make changes to the Medicare savings program. So this would be eligibility for the Medicare savings programs. Medicare savings programs help people with lower income to afford coverage under Medicare. So if they're eligible for Medicare, but they are lower income, they can receive financial assistance for the qualified Medicare beneficiary program. Sometimes people call it QIMBY. It helps pay Part A and B premiums and out-of-pocket costs. So this would increase the income threshold, which is not set in the statute. I think we use what the federal government sets as the minimums, which is currently just under 100% of the federal poverty level. This would increase that to 150% of the federal poverty level. It would eliminate the specified low-income Medicaid beneficiary SLIMB program, which is for people roughly just under 125% of the federal poverty level. It helps them pay their Part B premiums. It would get rid of that group entirely and increase the QI, qualifying individual program income threshold, from its current just under 138% of the federal poverty level to 185%. And that also helps just pay Part B premiums. Section 10 would direct the Department of Vermont Health Access to amend its rules and provider manuals as needed to ensure that children and young adults up to 26 years of age receive coverage for mental health services without a specific mental health diagnosis if they've had one or more of the following life experiences: separation from a parent or guardian due to incarceration or immigration, the death of a parent or guardian, the death of a family member or friend by suicide, a foster home placement, food insecurity or housing instability or both, exposure to domestic violence or other traumatic events, maltreatment, severe and persistent bullying, or experience of discrimination based on race, ethnicity, gender identity, sexual orientation, religion, learning differences, or disability. Section 11 is the first of a few reports. This would require on or before January 15th of next year that the Agency of Human Services provide to this committee and the Senate Health and Welfare Committee a proposal for providing small businesses with the option to purchase coverage for their employees through Vermont Medicaid, in addition to the existing option of purchasing health insurance coverage for their employees in plans offered through or outside the Vermont Health Benefit Exchange. So this is having them report on the potential for a public option or proposal for a public option for small businesses. Section 12 would have the Agency of Human Services again reporting by January 15th of next year to this committee and others a proposed schedule for sliding scale cost sharing requirements for Medicaid and Dr. Dinosaur beneficiaries, including the estimated fiscal impact of those cost sharing requirements. And it specifies that the proposed schedule shall not include any copayment requirements in excess of those in effect on January 1st of this year, so a date that's already passed, for Medicaid beneficiaries at or below 133% of the federal poverty level, and shall not include any prescription drug copayments for Dr. Dinosaur beneficiaries under 26 years of age. Section 13 would have the Agency of Human Services reporting again by next January 15th to this committee and others, recommendations for modifications to reimbursement rates for providers of specialty care services to increase access to those services for Medicaid and Dr. Dinosaur beneficiaries. Section 14 is a report on merged insurance markets. This would have the Agency of Human Services, in consultation with interested stakeholders, evaluate Vermont's health insurance markets to determine the potential advantages and disadvantages to individuals, small businesses, and large businesses, including the impacts on health insurance premiums and access to healthcare services of a few different options. One would be maintaining the current structure, so maintaining health insurance structure in which the individual and small group markets are merged. I guess that isn't the current, but it's the exception when we notwithstand the current status, and the large group market is separate. Moving to a fully merged market structure in which individuals, small groups, and large groups are merged into a single market, and moving to a fully separated market structure in which individuals, small groups, and large groups each purchase health insurance in a separate market. That report would also be due by January 15th, 2025. The findings and any recommendations for modifications to the current market structure report would be due. And in subsection C, this would appropriate $250,000 to the agency in FY25 to carry out that study. Section 15 directs the Agency of Human Services to request approval from the Centers for Medicare and Medicaid Services to amend Vermont's Medicaid state plan to make the adjustments to the income eligibility for the Medicaid savings programs as set forth in Section 9. And if amendments to the state plan are necessary to implement any other provision of the Act, then the agency must seek approval from CMS as expeditiously as possible to enable implementation of all provisions of this Act at the times specified in the Act. Finally, we have the effective dates. So the provisions on increasing eligibility for Dr. Dinosaur to income eligible adults up to 26 years of age, and the Dr. Dinosaur-like coverage in Section 8 would take effect on January 1st, 2025. On January 1st, 2026, the Medicaid rates for primary care and mental health services and for dental services would be increased. Those provisions would take effect. Section 9 on the income eligibility for the Medicare Savings Program would take effect upon approval by CMS of the amendment to Vermont's Medicaid state plan. In Section 7, the Clinical Utilization Review Board, a subdivision that changes the membership to have appointees by the governor, the speaker, and the pro tem, would take effect on passage, but the appointments to be made by the speaker and pro tem would occur upon the expiration of the terms of the members of the board serving as of the effective date of this act in an alternating manner until all members have been appointed to the board in compliance with the provisions of subdivision B1. So nobody gets kicked off the board, but as people's terms expire, it would alternate appointments between the speaker and pro tem until it was 4, 3, and 3. And the remaining provisions would take effect on passage. Obviously, some of them have their own time provisions baked into the language.
Great, thanks, Jen. Any questions for Jen on the language?
I have a question.
Yep, go ahead, Brian.
I'm trying to follow along, but I am kind of having a hard time just because of my own situation. So I'm sorry if you said this, but does it only look at creating a public option for Medicaid for the small business or small group market and not individual?
So this is looking at a public option for the small group market.
That's what it was. So we don't include the individual market.
Not as the bill is introduced. You can certainly do other things as a committee.
Thank you. I'll hold it further comments until we're actually working on the bill.
Great, thanks,
Thank
Brian. Great, thank you, Jen.
Sure.
So there's a lot here. We're going to break it up in segments like we have in other big bills, last year. We're starting Tuesday with section 9 on the Medicare Savings Program, income eligibility, which, just so everyone knows, that was also a bill on our wall. And so we've taken, H118, we've taken that language and put it in this bill. So we'll take testimony on that on Tuesday, and then, we'll work through the rest of the bill as we have time and we move on. Great. Anything else? Okay, then we can be done for the day. Thank you. Thank you, Jen. And we'll see everyone back on the